medical and dental considerations. I hope you're excited because this is probably the most important module. I know I may have said this about others as well, but I have found that it is this specific topic that most dentists and specialists are a little perplexed by, and it holds them back from seeing these patients in practice. So I hope by the end of this presentation, you feel a lot more confident in seeing patients. What are the learning objectives? We will be identifying some of the most common conditions you will be encountering in practice, learn their oral implications, figure out what kinds of medicines people are taking, what are their effects, and go over the pathophysiology pretty briefly about these medical comorbidities. We will learn what to ask in medical consultations, when to treat patients, when not to treat, and we will perform risk assessments as well as figure out what kinds of medical emergencies we need to be prepared for. So, medical histories, do they matter? Of course they do. That's a very obvious question. But to illustrate this point, I have a really fun case study that I'm going to share with you. So, a couple of weeks ago, I met one of my patients in person, and she said, very offhandedly, Doc, I had a mini heart attack 2 weeks ago. And this is in the middle of my team getting ready to set up for x rays. We're in the middle of doing a try in for her upper and lower partials. And I was absolutely not expecting a comment like that. So for a moment, I was just caught listening to her. And meanwhile, my lead assistant had not been following our conversation because she was busy putting something in the computer. So she was just like, Doc, we're ready for x rays. And I was like, hold on, we need a few minutes right now. So this is a picture of my patient's medical history from probably earlier in the year when she first came to us as a new patient. We typically update our medical histories once every year, preferably at the recall appointment. It is a good reminder to kind of do that. Or we will update it every time they have had a significant medical event in their lives. So she has had a few back surgeries. This patient has had both her knees replaced a few years ago. DVT runs in her family. Patient has a continuous glucose monitor, and she measured 197 at 2 or 2:30 p.m., which is probably an hour or an hour and a half after her lunch. She said at that time that her last A1C was an 8.4. She has had chronic kidney disease. She has rheumatic valve disease and has been advised to take antibiotics before dental visits. She is on insulin-dependent diabetes. She is on Eliquis, which is a blood thinner. So we have that check marked. And what's missing from here is a part of the history that my face is on right now, but she has had an NSTEMI before, which is a type of myocardial infarction in 2024. And she had the exact same thing. When what she was referring to as a mini heart attack is what she had recently. So a little bit more about this patient. She's 69, and her last recall with us was in August, where again we were in the process of delivering her upper and lower partials. So we were doing a try-in visit as well as a cleaning and things like that. In October, she calls us and tells us that her crown fell off, her crown on the upper left. And when we met her in person, she informs us of this mini heart attack. She does not mention it to the scheduler. The partial on the top is obviously dependent on the way the crown sits. And since the crown is off, now we need to do a new build-up, a new crown, possibly alter the partial for it to fit the new crown. Relevant social history, she lives alone. She's widowed. And she receives home care services at a family home which is almost an hour away. and she planned to stay with them until full recovery. What is full recovery? Full recovery after an NSTEMI ranges anywhere from 6 to 8 to 9 months. For the dental appointment, however, she chose to come back to our house. If you remember from the previous module, I do a lot of portable dentistry where I go to patients' homes and offer them services bedside. So this is a very critical piece of the element that I want to mention, because she has just had an NSTEMI earlier in the month, and now she has chosen to travel by herself, be alone at her home, simply for us to, get her partials, and for us to figure out what to do with the upper left crown that has gotten dislodged. Um, all of these things should kind of raise some thoughts in your mind, possibly raise red flags. Okay? This is a picture of kind of the before and after of that crown. You can see that there probably was sort of an open margin. The crown was starting to maybe dislodge before, but we had kind of kept it on hold, and we felt like, okay, we can still do the upper partial without disturbing that number 14. But of course, as luck would have it, it decided to come off. It came off with the build-up, and now we have to do it all over again, and that's okay. That's totally fine. So from the medical side, what are we concerned with? We sent a little note to her primary care physician telling them that we came to know that she's had an NSTEMI earlier this month and that 2 stents were placed in her heart. What are we supposed to be aware of before we see her for her next appointment? When is it safe to proceed for her next appointment, which will require local anesthetic? In the local anesthetic, we will use non-epi containing anesthetic, but still, we want to make sure it is safe to proceed. We will monitor her blood pressure throughout. Now, is this consultation, are these questions enough in your opinion? What would you have done? Would you even see this patient in office? Would you refer her somewhere else? And what are the other red flags in this scenario? There are plenty of red flags in this scenario, right? We are thinking about her diabetes, which is 8.4. We are thinking about the fact that she doesn't actually understand what an NSTEMI is. That is actually the most critical part, because she chose not to tell the scheduler who called her to confirm the appointment, and instead kind of just mentioned it very casually and offhandedly to me in person. What if she had chosen not to tell us at all? That could have happened too. How could we have prevented that? Should we be making it regular practice to be asking our questions, to be asking our patients, have there been any significant medical changes in the last few months since we have seen you? Have you been hospitalized? Have you had any surgeries? Sometimes you need to ask patients for them to remember, because think about it. Most people, when they visit the dentist, they're only thinking about their teeth. They're not thinking about the 100 other or million other things that are happening with their lives, right? So sometimes we need to be kind of the Sherlock Holmes and ask for these questions. So there are lots of potential problems with seeing this kind of patient in office, but again, it's not impossible. We just have to do our due diligence in making sure that the medical side of her life is stable before we proceed. So why again do medical histories matter? And I will put this in context with our patient. Medical fragility. Is she super fragile? Yes. Is she usually that fragile? No. But temporarily she is. She's just had a heart attack. She probably doesn't understand how significant it is and how much an anesthetic or how that procedure will, when it interacts with dental stresses, how it is going to impact her. She probably doesn't understand that. She also doesn't understand the fact that it's actually not very safe for her to be alone at this time, because anything can happen and then there will be no one at home to take care of her. She really should not have left her family home where she was receiving home care services. Patient safety. Is the patient safe at the moment? Well, when she's with us, she's safe. When she's alone, she's not safe. And that concerns me. Because when we see her for her dental appointment, we're there for maybe an hour and a half, and then we leave. What happens then? So there are all of these questions. We need to make sure our patients are safe even after we have left their home. This is so critical because a lot of patients actually have issues with this, especially when you're doing sedation. Lots of patients, um, special healthcare needs, have this complaint, especially their family members have had complaints against dentists about how once the sedation procedure is over, patients are kind of just left and no one follows up with them until like the next day. Whereas actually the next 2 to 3 hours after sedation are very, very critical for patient safety. And many times they are not given proper instructions on how to take care of themselves at that time, or what to do should they start to seize, or should they start to have some kind of apnea issues. We don't give them enough instructions to take care of themselves, and that's a problem. Alerts to the medical community. This patient is on insulin, okay, but her A1C is still 8.4. Is that high? Yes, it's a little high. I would much rather her be on a 6 score or a 5, somewhere in that level. When she's still 8.4, despite of taking insulin, 4 times a day, like she's probably taking it in the morning after she's woken up fasting, or she's probably taking it after every meal, right? They're taking it at these multiple junctures of the day, but still her A1C is a little high. So is that a concern? Yes, and dentists are the right people to make this alert to the medical community that, hey, I'm planning for, say, multiple extractions, and there's a very high chance for her to develop post-operative infection. If her A1C isn't better controlled, can we make sure that for the next 3 to 4 months, her A1C is coming into a range of 6, so that I can be safe to proceed with these extractions? And usually when you write consultations like that with the medical community, they take notice and they make changes. Polypharmacy. Now, this patient was on a long list of medications, but not as long as I have seen. I have seen patients on like 10, 15 medications. That's when polypharmacy really starts to become very problematic. Polypharmacy really means when a patient is on more than 5 drugs, and that many of these drugs seem to be additive, which means that maybe 2 or 3 of the drugs are doing basically the same thing. So we are giving patients more than what they need. It often happens when patients are seeing multiple medical providers, and each of those providers are not looking into what the other providers are offering in terms of medications. And this can happen to dentists too. If we don't know the full medication list of our patients, we are bound to prescribe something that is in excess of what they're already getting, which could run into huge issues. So this is something we have to be very, very critical of. Obviously, you want to try and protect your team and yourself. You do not want to start your day with a medical emergency of any kind. It's super duper stressful. You need to know how to time patients. When is the best time to see diabetic patients? Usually, there is a good time to see patients. Okay, so if the patient, for example, has cardiac issues, hypertension, I like to see these patients in the afternoon. I never like to schedule them in the morning. Why? Because most people in the morning are rushing to the dental appointment. They're already kind of stressed out by the time they sat in your chair. And now you're going to stress them out even more by adding anesthetic and by pulling teeth out. The anticipation of all of that is too much. Most patients are likely to have issues in the morning in a dental appointment if they are hypertensive or they are cardiac patients. So try to see these people in the afternoon. It's a lot more relaxed. Diabetic patients, best time to see them is in the morning because their blood sugar is usually better controlled as they have gone through the day. They have eaten stuff, they have had a large meal, they've had carbs, things like that. Things start to get haywire by the time the afternoon comes by. Always better to see diabetic patients first thing in the morning when their blood sugar is is more or less stable. And patient education. For example, this very patient, she did not really understand what an NSTEMI is, the fact that it's not really a mini heart attack, it's actually a proper heart attack, and that she really should be taking care of herself. And maybe some of it is our fault. As healthcare professionals, we don't take enough time to make patients understand what they have just gone through. So, this is a reminder for us to kind of make patients aware of the seriousness of their medical conditions and to take their own safety very, very seriously. Okay. Um, so, with that, we'll start with a deep dive on some of the most common medical conditions. GERD is super common to the point that we almost kind of passively ignore GERD, but we really shouldn't, because GERD can have implications in so many other comorbidities. And specifically, I should have highlighted this in red, but obstructive sleep apnea. A lot of patients with sleep apnea happen to also have GERD. So please be aware of this. Patients with GERD tend to have aspiration risks, so maybe they are not the best patients for us to do sedation on. So think about that. If you have a patient who has GERD, you're sending them out for sedation, hey, maybe they're not going to get accepted for sedation because they're just not a good candidate for it. So remember that. Lying supine for them makes everything worse. Ask any uh, pregnant individual, they will tell you, because 50% of pregnant women have had GERD at some point during their pregnancy, particularly the third trimester. So they will tell you lying supine makes everything worse. Always have them at an incline or have them sit up. Many patients with GERD will show dental erosion, xerostomia, that's usually caused by some of the medications they're on. And of course, related to all of this is high caries risk. So you might not want to use traditional composites in such patients. You might want to consider glass ionomer. Of course, there's nothing preventing you from using traditional composites too. Isolation is really key, and understanding your patient's caries risk is key. Strict bonding protocol, and of course, we would consider occlusal guards. Hypertension and cardiac disease. I kind of brushed on this a little during our case study, but the biggest issue here that I see is a lot of dentists and specialists worry about patients being on anticoagulants. A lot of patients are on anticoagulants now. It's really, it is also my patient population that tends to be focused on patients with chronic medical conditions. But believe me, the number of patients on anticoagulants has just kind of skyrocketed over time. So you will be seeing these patients more and more often. Do we stop anticoagulants for any kind of dental treatment? Not really. We take precautions, but we don't stop them, because the risk for the patient to develop a stroke or a significant cardiac event in your chair is actually much higher than from them bleeding out from an extraction. You might limit the number of extractions you do. You might try to do very simple extractions, try not to do surgical things that might increase the risk of bleeding. So just do simple, easy surgeries as much as you can. Use hemostatic measures, but you really don't need to be stopping anticoagulants. Okay. And that has been released by the ADA guidelines as well. You need to know when to prescribe antibiotics, and that is pretty clear on the AHA guidelines as well. Know when the blood pressure is high. Have blood pressure checked routinely for every single appointment. If it's a simple denture try-in or something small, yes, maybe you don't need to check blood pressure, but in my opinion, it's always kind of nice to have, because then you can see a pattern. If the patient is coming for a simple appointment and still having very high blood pressure, you know that this is an issue, and you can again create an alert to the medical community. A very important thing that many of us actually forget is anesthetic dosage. We are so used to push an anesthetic if the patient is not fully numb. And then maybe sometimes we forget to calculate how much we are using. Anesthetic quickly adds up. If you are using Septocaine especially, it's going to add up very, very fast. Have that mental math or use an app. There are lots of apps on the market now where you can calculate anesthetic dosage, and you can just have it written on a piece of paper next to the laboratory that says I can use a max of 6 carbules on this patient if I'm going to use Septo, or I can use a max of 10 if I'm going to use Lido. I typically always have that written by my dental assistant. I have them run the math and write the number if you're doing more than 5 or 6 extractions, if it's like multiple extractions in one visit, because you are going to forget to run the math when you're in the middle of the procedure. So seeing that number right next to you will help you. Of course, this patient population, again, you will see xerostomia, a high caries risk. That's mostly because of their medications. As I mentioned before, schedule afternoon appointments, focus on stress reduction, and they need to be profoundly numb. If they're not going to be numb, they are going to start getting stressed out, which will make everything worse. Chronic kidney disease. My patient had chronic kidney disease as well. Luckily, she was not on dialysis, but you will start seeing patients having kidney failure that are starting to go through dialysis. Dialysis is typically 2 or 3 times a day, 2 or 3 times a week. And should you be scheduling treatment on dialysis days or non-dialysis days? So many considerations, right? If you're doing extensive treatment, I would always schedule treatment after dialysis. So the day after dialysis, I would see them, not on the day of dialysis. If it's a small treatment, like you're trying in a denture or trying in a little partial, doing some silver diamine fluoride on a few teeth, those are very small chill appointments, 15-30 minutes max. You can schedule them after dialysis, but believe me, patients are super exhausted after dialysis. Dialysis takes a lot out of you. Patients are in the center for maybe 3 to 4 hours. They are exhausted, and for them to come to a private practice to get dental appointments done, most of them are not going to want to do that. They will want to come in the next day. There have been studies that have discussed whether we should see patients before dialysis, like the day before dialysis or the day after dialysis. In my experience and from what I've seen in residency, we have always seen patients the day after dialysis, and in my experience, that has always gone pretty well. So that's what I would recommend also. But there have been studies comparing both, and they are more or less kind of the same. You might see some platelet dysfunction, and that's really what the consideration is, right? It's the bleeding that we are worried about. Many medications cause xerostomia, cause a metallic taste, and we do tend to see some perio disease. Think about also medications that are usually metabolized through the renal system. Think about common analgesics, antibiotics, or sedatives that you usually would prescribe to a regular patient. You might need to modify or change the medications for someone with kidney disease. Arthritis or a fall risk. I define fall risk a little bit differently. If I see anyone on a wheelchair, I will typically put them under a fall risk. But fall risk is actually really, really big, and it's a very comprehensive term, and it's used for anyone that is undergoing any kind of cognitive decline, okay? Whether it is medically recognized yet or not, or it's something only you have recognized in your practice, you're going to put them under a fall risk. The biggest issues that I have seen in dental practices with regards to fall risks or someone with arthritis is when we try to transfer patients from the wheelchair to the dental chair, which is why I would always recommend don't transfer patients. And I know that there's lots of dentists and specialists that will hate that I say this, because you're so used to seeing patients in a dental chair, and you know how ergonomically challenging it is to see a patient and do treatment with them. treatment on them while they are in their wheelchair and you're standing and hunched over, believe me, you're saving yourself a lot of heartache, because transferring patients actually requires, depending on which state you are in, requires certain kinds of training that your team needs to have. Should you be transferring patients yourself? Should you have your team transfer them? It doesn't matter. There needs to be some kind of legal contract that your team has signed off saying that they are okay transferring patients. The weight of the patient is a big consideration. A lot of our patients are now weighing 150, 160, 180, 200 pounds or more. How safe is it for your team to be transferring this patient? You can run into a whole lot of liability concerns over here. It's not very safe for the team. It's not really safe for the patient. If the patient insists, or if you insist on being transferred to a dental chair, then I would always have the caregivers do it, right? Patients come with caregivers. Typically, these kinds of patients will always come with caregivers. Let them take care of it. Let them transfer the patient to the chair. They know how to do it. They do it all the time. Don't get involved with it. That's at least my recommendation. It will save you a lot of mental and heartache. Typically, these patients are going to have pain, stiffness, fatigue in the joints. Everything is very uncomfortable. How much ever you can help them in making the dental chair or even sitting on their wheelchair as comfortable as possible is better. And I will show you some kinds of tools that I use in probably the following slides or in another module. But I will show you what we can do to give the patient more comfort. Think about NSAIDs or steroids, how those would affect our patients with fall risks. And of course, many of these patients might have reduced manual dexterity because of arthritis. So figure out how that is impacting their oral hygiene maintenance. Many of them will be depending on their caregivers to brush their teeth for them. Diabetes. So again, our case study had something going on with diabetes, and I already mentioned her A1C was a little bit high, at least for my liking. I don't like for it to be that high if the patient is already on insulin. But there is a rising incidence of diabetes in the United States. A lot of patients now are on GLP-1s. GLP-1s, the main thing you need to know is that they cause delayed gastric emptying. That's how they work. So they make the stomach feel full for longer, which is why patients are compelled not to eat as much, and that's how they lose weight. This is something important to know if you're seeing patients for sedation. So if you're doing sedation in the morning, you might have to adjust the dosage of their GLPs the night before so that their stomachs are not that full when they come in for a procedure, because that will affect your sedation. That will cause an aspiration risk for them. Morning appointments, as I mentioned before, are usually much better for diabetic patients. Many patients are on continuous glucose monitors. There's the Libre, there's Lingo, there's so many apps now that can give you lots and lots of data. If my patient is on a CGM, I typically will look at their records to see how well their diabetes is controlled throughout the day. If it's within a normal range, I don't worry as much, and I don't push the primary care physician to alter their dosage. If I know that it's pretty consistent, I'm not as worried. If it's kind of erratic, then I will talk to the physician. Patients with diabetes, unfortunately, do tend to have a higher risk for caries as well as periodontitis, so they need to be taken care of pretty well. Are implants a good consideration for patients with diabetes? Yes and no. It really depends on how well their diabetes is controlled. If they are well controlled, then you can definitely do implants, but it does pose quite a few risks with it. Parkinson's, we are starting to see a lot more patients with Parkinson's as well. So Parkinson's basically involves impaired mobility, again, increased fall risk. They typically require full-time caregiver support Most of these patients can be pretty challenging to see in a dental operatory. Some of them will come with a wheelchair. It's just hard to see these patients, especially if you're doing long treatments, because typically shorter appointments are better for them. But if you have a long procedure like a crown prep, which is going to take you 2 hours or at least an hour and a half if you're very efficient, it's still a lot for a patient with Parkinson's. So you have to kind of time the procedure in a way that the patient is at their best. Um, Always try to schedule patients shortly after they've taken their medications, and mid morning is better. Nitrous actually works really well. Using muscle relaxants and things like that is actually not recommended at all for Parkinson's. You want to just try to time it after they have taken their medication, like a levodopa or a carbidopa. And again, nitrous works much better for patients. IDD. IDD is indistinguishable. You might see a patient and you might have no idea that they have an intellectual and developmental disability. You will typically find that out only if they mention it in a medical history. But again, you see polypharmacy here, you might see seizures, and maybe some mental health conditions. Seizures, for the most part, are very, very well controlled. I have never seen a patient that has had like an uncontrolled seizure. Even though I see this patient population all the time and I've been seeing them for so many years. So that incidence is pretty rare. High incidence again of caries, decay, perio, and malocclusion. But again, a lot of this is not because the patients are genetically predisposed or medically predisposed to these conditions. It's basically because of a lack of access to care. That's the reason for these conditions. So you might see someone with IDD who doesn't have any decay or any gum issues, and you know that they have had actually great dental care since the beginning, and that's awesome. Some patients require AACs. AACs are alternative and augmentative communication devices. Think of an iPad. There's also other devices where they have kind of a screen in front of them, and with their eyes, they look at different letters, and then those come at the other end of the screen as words. Typically, communicating with patients using these tools takes longer time. So you have to account for that time in your scheduling patients. So when your scheduler is making these appointments, they need to ask, hey, are you using any kind of alternative or augmentative communication device that we need to know of? Do you need us to provide pen and paper, iPads to communicate? What works for you? Let us know. And then you go over scheduling as well as consistency. Down syndrome. Down syndrome is a condition caused by trisomy 21. Midfacial hyperplasia, low set ears, and a broad, short head are the typical physical anomalies that are associated with someone with Down syndrome. You might see patients with cardiovascular complications typically at birth, and these complications might have already been corrected by the time you come into the picture, but most patients with Down syndrome have a annual consultation with their cardiologist regardless. So it's nice to keep that in mind. If you were to take them to the operating room or to do sedation, you would have to include the cardiologist in your communication. Some patients unfortunately have a high risk of developing obstructive sleep apnea. This is another consideration if you're seeing patients for sedation as well as in the operating room. And a lot of patients with Down syndrome, unfortunately, will be in the overweight to obese category, again making them difficult for sedation and operating room procedures. You might see a high incidence of perio, decay, as well as spaced teeth. Again, the decay and perio is mostly because of lack of access to care, not because they are medically or genetically predisposed to these conditions. I have also seen that patients with Down syndrome can actually be really, really great patients. You need to keep them on a strict recall period of 3 months. 3 months is like my minimum that I want to see patients at. Um, and many patients can actually be candidates for ortho down the line, but all of that is dependent on their compliance, and it's very specific and very, very patient driven. Cerebral palsy. So, cerebral palsy is actually abnormal development or damage to the brain either before birth, during the birthing process, or sometime during the first 5 years of a child's life. Typically associated with feeding difficulties, undernourishment, you'll see that they have diminished swallowing reflexes. Again, all of these things are considerations for sedation and operating room procedures, which is why it's so important to see them in private practice so we can prevent hospital dentistry. Some of them might have seizures. Again, they're typically well controlled if they're on medication. What you're really looking for is someone that will be having signs of GERD. They will be drooling. Many of them just come with bibs. They always have a bib constantly. And if you're seeing them bedside, they will have suction available as well. So you don't have to use your own suction because they already have it there. Patients with cerebral palsy are relying on their caregivers 24/7. Usually, there will be a daytime caregiver, there will be a nighttime caregiver. Most of them are consistently in bed, or if they have to go for appointments, they will be on a wheelchair. Using the open wide disposable mouth prop has been really great because of the motor reflexes in these patients. So I typically have my assistant prop their mouth open with the mouth prop, and I will do my exam or my cleaning or any kind of treatment on the other side, and then we will do a dance and we switch. I also always bring the three-sided toothbrush, and I have a picture of it in one of the subsequent modules. We will have the caregiver sit with us and we will go over how to use three-sided toothbrush, because remember, these patients are not brushing by themselves. They are having support from a caregiver in doing that. So caregiver education, super duper critical. Dementia. Unfortunately, the rise in dementia also means that we are seeing more and more of these patients in our practice. So patients who never ever showed you signs of cognitive decline are now showing you signs of cognitive decline. They're starting to develop conditions like dementia or Alzheimer's. Dementia is basically loss of intellectual function to a point after which maintenance of regular social and occupational activities becomes quite challenging. Communication with patients with dementia is both verbal and non-verbal. I usually stand on the side of the patient and always have a hand on their shoulder, just as a kind of reassurance. But I almost always will do that, not just for patients with dementia, but every other patient. Patients with dementia, I've noticed, they really thrive and do 1,000 times better if they have a family member or a caregiver that they know, that they're familiar with, sitting in front of them when you are treating them for dentistry. So when you're doing x-rays, you're doing fillings, crowns, whatever it is, have the person they know well to sit in front of them. Everything will go better if you have someone holding their hand. Anything to do with familiarity will help. If you don't have a person like that, it's going to be very challenging to get them to comply with any treatment. Always ask, when are these patients at their best? You can give rewards. I am not a big fan of using TV or any kind of cartoons, but sometimes it's nice to have that little tool nearby. I have a case study eventually where I do talk about how songs and music can help a lot of our patients go through treatment. Tolerance of a prosthesis, this is very tricky. If someone is showing cognitive decline, the chances of them adjusting to a new partial or a new denture is really, really tricky for us to establish. You need to have lots and lots of conversations with the POA, with the family, with the patient themselves to see how well they might be doing, how well they could do with a new appliance in their mouth. And that is a judgment call that only you can make. I feel it's always important to have a mentor in these kinds of situations that you can discuss the patient with on an objective basis, of course, with the permission of the family. But it might help to have an objective third party in this scenario to help make the decision. A lot of patients are suffering from hearing issues, so make sure they have their hearing aids on, otherwise they're going to get so frustrated with you when you come in for their appointments. I have had this experience multiple times, so I know from experience to always ask if they have hearing aids, please let them wear it and let it be loud enough that they can hear me properly. Because like many of you, I am also very soft spoken, and sometimes patients have no idea what I'm saying. Financing can be tricky. Most patients with dementia or Alzheimer's are being financially supported by family members, and so getting that kind of squared away before is important. These are the 5 M's of geriatric patients that the medical community follows, which is important for us to know. What medications are they on? Review, review, review. Reduce the incidence of polypharmacy at all costs. Mentation. What is their cognition like? Are they starting to show decline? Assess for dementia, delirium, depression, and their decision-making capacity. We need to do this as dentists because, believe it or not, we are sometimes seeing our patients more often than they are seeing their physicians, who they're maybe seeing once a year. So we can be a very, very critical piece of the puzzle in making the medical community aware that this patient is starting to slip a little bit. Medical comorbidities, figure out how their various medical conditions are interacting and affecting each other, especially important for us to know as dentists. What matters most? I think this is so important because patients have different goals for themselves. I had a patient who just had a goal of trying to live her best life until she's no longer able to, and she was on a DNR status, which is do not resuscitate. So she is not looking for anything major. She just wants to have a high quality of life until she can no longer do it, and she doesn't want to be resuscitated if anything adverse were to happen to her. So figure out what matters most for your patients. That specific patient that I mentioned, she just wanted her front teeth to be replaced. She just wanted to be able to smile when she is on video with her grandkids, with her friends, and just kind of try and have the best quality of life possible until she could no longer have that. And mobility, we need to be implementing strategies to prevent falls, which I've already gone into much detail in the previous slides, so I will not harp on that anymore. The purpose of medical consults is really for us to have our questions answered. If you just send a blank form to the medical community, they are going to just send you a history and physical back, and they're going to tick mark a line that says patient cleared for dental treatment, which doesn't give us a whole lot of information. If you ask no questions, you are going to get no answers. So ask questions, because the medical community does want to help us. They want us to help our patients have a better quality of life. Always send medical consults if the medication list is not making sense. You see the patient, you're seeing them frail, you're seeing them a little sick, and yet they're taking maybe just 1 or 2 medications. That's not making sense. Or they have cardiac instability, some kind of new activity in their medication history. You are sending this patient out for sedation, operating room dentistry. You need a history and physical. Never ever treat a stranger. These are some of my favorite tips. This podcast has been really, really great for me to understand pathophysiology of various medical conditions. It's called the Curbside Internal Medicine Podcast. It's one of the top rated podcasts amongst physicians. Epocrates and Up to Date are 2 paid subscription based apps where you can check for drug interactions, side effects, and pharmacology of different medications. So if I see something I I cannot immediately recognize which class of drugs this falls in or what effects are they going to have on my patient, I will first plug it in to one of these apps. And there's ChatGPT, of course, which is great to create workflows for handling different medical emergencies, questions to ask when common medical conditions pop up. We have cheat sheets for different medical conditions that I use to help educate my team members, because a lot of the work is done by our teams as well. We can't do everything, right? So using ChatGPT for this has been a time saver, huge time saver. So utilize AI when you can. The most common medical emergencies that you might see, that I have definitely seen, are hypoglycemia, syncope, and panic attacks. Some of the others, we worry about them a lot, but the chances of us actually seeing them are pretty low. You should know how to manage these medical emergencies in your office. You should always travel with your medical emergency kit, not just for patients with medical complexities or patients with special healthcare needs, but for everyone. Um, and think about airway, think about how everything is affecting the airway of our patient, and be that person who can maybe create a life-changing effect or impact on our patients by thinking about their airways. You should have a medical cart, which is technically on wheels, so it's portable and it can go from one op to the other should you need it. It's typically called a crash cart and it's available in most hospitals. But having that in your dental office would be so nice, especially if you have pamphlets that go along with it that tell you what to do with each kind of medical emergency. It needs to be very easy, because believe me, when a true emergency takes place, our brains stop working. You need to be able to see what to do so you can take care of it right away. When it's an emergency, your brain will stop working, so you just need to make it very easy for yourself. And the way we practice medical emergencies in our specific setup is we have monthly simulations. We do like little case studies, and then we ask questions to each other. What would you have done? What would you have done? And we actually simulate it. So we will have someone pretending to be a patient, having an episode, and then our team of 2 or 3 goes to take care of them during dental treatment, and then they have to figure out who is the leader, who is, the second in charge, third in charge, and what they would do. And that really helps. And then we have a debriefing session after that. So I hope this has helped all of you. You have come away with a lot more information than you probably had when we first started this module. As I've said before, this is kind of the meat and potatoes of this entire lecture series. It's what holds most people back from seeing these patients. And I hope you've come away gathering more value. I will see you in module 3. Bye.